A very good day, my dear postgraduate students. I hope you all remember the term SNIP, short notes in pathology. And there is a dual purpose in my presentation today. One is covering a topic, and two, explaining the subtleness in such topics as PEComa. By definition, it is a benign to borderline, mostly a peripheral neoplasm derived from the perivascular epithelioid cells. That is why P, E, and C. Perivascular epithelioid cells, there is a tumor, and hence the term PEComa. Also, there are certain other terminologies which are related or closely aligned with it, which we should have in mind, such as the PEComa 1, 2, myomelanocytoma, and angiomyolipoma. Then the third one can be lymphangiomyomatosis. Why these are all important is there can be a common derivation, there can be a common morphology, or even an immunohistochemistry. So we shall have that in mind. Thanks to this reference. And histologically, what we are supposed to see is large, clear cells, which are positive for PAS. And this is, of course, a specimen of a lung, and I am finding a peripheral, well circumscribed tumor. The cut surface is more or less homogeneous, and there is not much of hemorrhage or necrosis in this picture. Courtesy pathology outlines. And the essential features, these are certain subheadings that the pathology outlines has been handling the topic with. So it is a rare benign tumor derived from the peripheral epithelioid cells, PEComa, clear eosinophilic granular cytoplasm. And it can be positive for the melanocytic as well as the smooth muscle markers as well. Look at this one. It is not the lung per se. It is probably the liver or any parenchymal organ wherein there are large clusters of cells. Absolutely a clear cytoplasm which mimics a renal cell cancer. So there is a central nucleus, hyperchromatic, and nests of cells. Please remember this word, nests of cells. By epidemiology, it is a rare tumor, and no difference between the male or female, and around 40 years is the age that has been mentioned. The site specifically, it is not limited to the lung. It can be the peripheral lung, any parenchymal organ, female genital tract. In fact, this is a specimen of a uterus with a malignant PEComa. Skin, peritoneum, etc. And the pathophysiology is patients who are already with tuberous sclerosis or lymphangiomatosis are more prone to have this one. It belongs to a family called the PEComa family, which I had mentioned. So we will have to mention each and every point that I had defined so far. Clinically, it is asymptomatic and non-specific. Radiologically, it is a solitary, homogeneous, and a circumscribed lesion. As you are seeing in this picture, it is a specimen of the lung again, with the anthracotic pigment here and there. Hyperintense due to increased vascularity. The prognosis depends on the nuclear pleomorphism, mitotic activity, necrosis, etc., all together which are pointing towards an aggression and might result in a malignant transformation as well as metastasis. Grossly, it is about 5 centimeters and tan in color. Microscopy is more important. So, there are certain keywords which I would like you to follow. Organoid. Organoid means it is something like an endometrium, where you have got groups of cells or glands. There is no duct or anything. And that is called as an organoid pattern, which you see in a carcinoid. So the tumor cells can be in cords or in nests. Roughly, if I can imagine, there are nests of cells in between the highly vascularized tissue over here. Very rare mitosis, and I am able to see a clear cytoplasm. Areas of calcification can be there, and the stroma may show sclerosis or desmoplasia. There are certain spider cells with nuclear condensation, and these can be entrapping or encircling the peripheral airways. So this is something that we should remember. The pattern, the nature of the cells, and the location. This is a different picture again. In this, I am finding a little bit of pleomorphism. Darker nuclei which are larger, pleomorphic. But what the author has pointed out in this is the intranuclear inclusions. There are certain intranuclear inclusions which he, however, said is not very significant. Pseudo inclusions. So electron microscopically they are somewhat perivascular in location. And the presentation can be this. So you find in this case it is the periphery of the lung located in the mediastinum. This I had already pointed out. So there can be a benign PEComa which encompasses all this, or there is a malignant PEComa not otherwise specified. If you remember these two things, it are more than enough. And the sites I have mentioned, uterus, kidney, liver, lung, as well as the abdomen, retroperitoneum, etc. So there is a beautiful series of pictures. So we shall go word by word. In A to B, there is a huge mass and it is measuring this much. Is it clear? In A as well as in B. There is a flank mass over here. Whereas in C, both the lungs are involved with something like a cannonball appearance, probably multiple metastases. Thanks to this picture from Science Direct, and this is the reference. Molecular and cytogenetics, TSC2 loss of heterogeneity when arises in a patient with tuberous sclerosis. So, it is this heterogeneity, particularly in a patient with tuberous sclerosis, which can preclude to PEComa. The differential diagnoses are important. Where all can we have a clear cytoplasm? Metastatic tumors, particularly a renal cell carcinoma or an adenocarcinoma. Clear cell sarcoma is another one. Carcinoma again, melanoma. Probably he means a amelanotic melanoma and paraganglionoma. So these are certain important differential diagnoses which we should bear in mind.